Good evening, and welcome to tonight's Men's Health webinar with Dr. Itai Goldenberg. Tonight, Dr. Goldenberg will discuss the signs, symptoms, and treatment options for stress urinary incontinence, and then discuss same for erectile dysfunction. You're encouraged to ask questions anytime during this webinar. I just ask that you go to the chat function. It's either on the bottom of your screen. If you're using a mobile device, it'll be in a scroll down menu. Type your question in, submit it, and Dr. Goldenberg will answer it at the conclusion of the presentation. So without further delay, I'd like to introduce Dr. Itai Goldenberg.
Hello, hi everyone. Thank you all for signing in and taking some time for your evening to listen to this presentation. I going to talk about a couple issues today, focusing on men's health, talking about erectile dysfunction, and as well as stress urinary incontinence in men. Like Mike mentioned, this is an open dialogue. It's, the idea of these talks is really to provide education. And so please put questions in, and I'm happy to take time at kind of the halfway point and at the end and to answer questions. We're very lucky to have Cliff Pollack, who's going to talk about his experience at the end, and Cliff is also great at answering questions about his experience when we're finished. So this is me. I definitely look younger in that picture, but my name is Itai Goldenberg. I'm one of the urologists here at Urology of St. Louis. We are a private group of urologists. There's 27 of us spreading kind of everywhere in the St. Louis metro area, in St. Louis and in Illinois. I did my residency training in urology at WashU, and then I went to New York and did a fellowship specifically in men's health, focusing on men's sexual function, urinary function, as well as fertility treatments. That's really what my practice is focusing really in men's health issues. I really enjoy taking care of men with these issues, and like taking care of men in the office and doing the surgeries, and happy to help anyone out that's on this call. So I will start this talk. I'm going to focus first about stress incontinence and what it is and how it can be treated. So if you think about the urinary process, not pictured here up high are the kidneys. The kidneys make urine. The urine then comes and fills the bladder. I like to think of the bladder as almost like a water balloon. The idea is the bladder is a muscle that is elastic and is able to stretch and allow the urine to fill the bladder. The bladder usually holds somewhere between 350 and 500 milliliters. When the bladder fills, then the muscle that's seen here around here squeezes and pushes the urine out. The urine then goes through this urethra that's pictured here, and the urethra runs through the prostate, and then there's this muscle here at the bottom of the prostate called the sphincter. When the bladder's full and you don't want urine to flow, the prostate has an internal sphincter and there's an external sphincter here outside the prostate, and those are always collapsed, keeping the urine inside the bladder until you want to relax those muscles and let the urine flow. So incontinence happens when urine leaks involuntarily. There's two major types of incontinence. One is stress urinary incontinence, and that's what I'm going to focus on mostly today. Stress incontinence is when a man coughs, sneezes, lifts something heavy, really puts a stress or extra pressure onto the bladder. When that extra stress occurs, that energy then pushes on the bladder. And if you don't have appropriate musculature and protection, the urine can then leak out, overwhelming that sphincter mechanism. The other type of incontinence is urge incontinence. So urge incontinence is different. It's when the bladder itself becomes hyperactive or overexcited, and the bladder then squeezes and pushes the urine out involuntarily by squeezing too quickly and pushing the urine beyond the sphincter mechanisms by having a higher pressure than what those muscles can accommodate. Some men do have a combination of both these types of leakage. So stress incontinence really does correlate strongly to men that had prostate cancer treatment. So going back here to slides, if you look here, here's the bladder, here is the prostate, and here's that sphincter mechanism. When there's damage to the prostate because of prostate removal or prostate surgeries for enlarged prostate, you lose the internal muscle that's in here. In addition, sometimes the sphincter muscle, either that's left behind, isn't strong enough to maintain the urine inside the bladder, or is damaged as part of those procedures, and therefore you don't have the ability to keep the urine from leaking. So very common to have leakage right after your prostate is removed. Almost all men have some leakage initially. Within the first year of prostate surgery, most men have improvement of their stress incontinence, be it to about 10% of men still have significant leakage, which I consider more than a pad a day a year after their surgery. Together with prostate cancer treatment, things like neurologic disorders, enlarged prostate, radiation therapy for the prostate, or pelvic trauma can also contribute to stress incontinence. So urinary incontinence can have a high impact on a man's quality of life for many reasons listed here on the slide. So what can be done? This slide talks about, similar to what I talked about before, this is looking at the bladder in a different direction, where the bladder sits here. This is the prostate gland, and here's the urethra. When a man has a radical prostatectomy and the prostate is removed, an incision is made here at the bladder neck, and here one at the end of the prostate, and then the prostate's removed. The nerves that run into the prostate are normally peeled off the prostate in what's called the nerve-sparing prostatectomy, sparing those nerves and allowing them to still function. You can see here the nerves remained after the prostate's removed. Those nerves are important for erectile function. I'll talk about those a bit as we continue. And then the urethra is then sewn back to the bladder. At this point, you only have the external sphincter there to protect against leakage. Very common to have a radical prostatectomy done in the United States. There are about 70,000 done per year, most of them done robotically. And the robotic prostatectomy has reduced the risk of incontinence after surgery, but there still is very common to have men with significant leakage after their prostate's been taken out. So what are the treatment options? Normally in the short term, especially in that first year after the prostate's removed, or you had a prostate surgery for enlarged prostate, it's really modifying behavior is the way to go, reducing fluids before activities, especially and trying to empty your bladder before you are going to do an activity that's going to increase stress onto your bladder. Pelvic floor strengthening exercises. So to help that external sphincter get stronger, you can do Kegel exercises. Kegel exercises are muscle strengthening exercises that are also done by women after childbirth to regain those pelvic floor muscles. Men can do these muscle exercises in order to re-strengthen the pelvic floor. In addition, a pelvic floor physical therapist can help a man do a better job of really finding those muscles and strengthening them. And I've had a really nice luck with men getting better control of their muscles because they've done pelvic floor physical therapy. Coping mechanisms like pads and diapers and external catheters are really a way to hold the leakage, and also is the way that us as urologists measure how much leakage a man is having. When a man comes in and says, I have incontinence, the first question I usually ask them is, how many pads or diapers do they wear per day, as a quantification of how much they're leaking. That pad use can be a significant stress on a man's quality of life, and in terms of costs. And if you look at this slide, they calculate if someone's wearing 5 pads per day for 5 years, that can cost over $7,000. So I'm jumping here to treatment options. The idea is in the short term, doing those behavioral mechanisms, limiting fluids, empty your bladder before activities really can help. Normally, I like to at least wait a year after someone has had their prostate removed to really assess how much leakage they're having. Some guys continue to improve. If you continue to improve, we keep an eye on it until you really plateau. But if a man has significant enough bother from leakage over a year after their prostate's removed and they're not continuing to improve, I'd like to at least discuss with them some of these long-term options, things that can hopefully fix the leakage more permanently. And those options are doing a male sling or doing an artificial urinary sphincter. And I'm going to talk about these two individually in a moment, but in kind of more broadly terms, the male sling is a procedure where we put a piece of mesh underneath that sphincter mechanism. So you have to have a sphincter that's intact and working, and we give it a better backbone so that when you cough or sneeze or lift something heavy, the sphincter you have left behind has some additional support. An artificial sphincter is something placed for a man who either has failed to sling or that mechanism really doesn't work at all. And we need to replicate or replace that type of mechanism by putting in an artificial sphincter device, which I'll show in more detail in a moment, that really takes over that stress incontinence control. All right, so a male sling. So the most common sling that I place is something called an advanced male sling. The way it works here, if you look at these pictures, is this blue is illustrating that remaining muscle, that external sphincter that's left behind after the prostate's removed. We make a small incision under the scrotum, kind of in the perineal area, and we find the urethra and find this extra tissue here that's on the outer part of the urethra. We put this mesh on top of it and then loop that mesh through an opening in the hip bones. And what happens is when we tighten that up, it pulls that mesh here, giving extra support to that external sphincter. And you see how the blue line from there becomes longer there, showing that there's a higher area of compression. The muscle is able to function better. It's repositioned in a place that should work better. This surgery really works well only for men that muscle works. So in order to evaluate how well the muscle is working, we do a cystoscopy, or we look in with a camera in the office and look to make sure there's still muscle that's functional to some degree. And in my mind, I think this surgery is really best for guys with mild to moderate incontinence. That in my mind is 3 to 4 pads or less per day. If you have severe incontinence, that usually means that muscle is not going to be strong enough that even with the sling in place, that you will have the support you need. In addition, patients with radiation for prostate cancer in conjunction with surgery tend not to do as well with the surgery as men that only have their prostate removed. There's a high satisfaction rate with the surgery. Over 90% of patients are satisfied, especially if you have correct patient selection. In addition, over 90% of men would recommend this surgery to a friend. This is a minimally invasive procedure. It can be done either as an outpatient or with a 23-hour stay. I do leave a catheter in for overnight for men because there is some swelling after the procedure, making it difficult to urinate. Some men have difficulty with the catheter, and so we keep them overnight. Some men go home with the catheter and have it removed the next day in the office. Once the device is in place, you need to allow it to heal in place. So it's about 6 weeks of really light activity to allow kind of everything to heal and for the sling to get positioned permanently where it's going to stay. So you really have to take it easy for about 6 weeks afterwards without heavy lifting, straining, or sexual activity. Once it's all healed up, though, and the sling is in place, you really don't have to interact with the device. It should heal in a place that you should be able to urinate normally without having to interact with it, not having to push any buttons or do anything for the sling to work. It's always in there and does work well. If, like I mentioned before, the sling does not work, or you're not a candidate for a sling due to the severity of your incontinence, or because of radiation damage, or other reasons, we can talk about putting in an artificial urinary sphincter. An artificial sphincter has 3 components: a cuff that sits around the urethra. This cuff mimics, or is an artificial way of giving that circular muscle that stops the leakage. So what we do with the surgery is find an area and put this cuff around the urethra itself, and then connected to it is a little control pump that you interact with in order to control that cuff. The pressure comes from a small balloon that's in kind of the lower abdominal area. That's what's called a pressure regulating balloon. This is always putting some degree of pressure on the urethra until you press a button to open the urethra to allow allow yourself to urinate. Here is a animation of how this device would work. You see the cuff that sits here inside the scrotum in the scrotal skin. You squeeze that. When you give it these small squeezes, the cuff opens, allowing the urine to flow. And then after about 2 to 3 minutes, the cuff then closes back up again, allowing protection from leakage at all other times until you press that button again. It's a highly satisfactory procedure. Well over 90% of guys are happy they had it done. No, over 90% of men that had an artificial sphincter placed would recommend it to a friend. This is the gold standard as it for men that have a weakened sphincter that's not able to function and hold the urine. It mimics the way the healthy sphincter worked beforehand. Everything is placed inside the body, really is undetectable to others, but you can interact with it as it's palpable, or you can feel it under the scrotal skin. It's a high satisfaction. And in my practice, I do lots of different types of surgeries, and I would say my happiest patients are these men, the men that had artificial sphincters placed. These are often men that leak 6, 7, 8 pads in a day. And if we put a successful artificial sphincter in, they go to 0 or 1 pads per day and are very happy, really changing their quality of life. Risks, these are both surgical procedures, and so do have risks. With the male sling, it's possible that we put the device in and either make it too tight, where it's difficult to urinate, we make it too loose, where there is still some leakage, or they have irritation or pain from that sling that's in there. An artificial sphincter, when it's placed, it also has risks. It's a bit more of a complicated device, so a little higher risk of having issues with the procedure, including device malfunction. The average device should last somewhere between 10 to 15 years. But I have seen them last longer. I have seen them break down earlier than that, but the average device should last around 10 years or so, but may require revision surgery when it no longer functions. It may cause irritation or erosion to the urethra, necessitating removal. Again, we may put the device in either too tight or too loose, causing either some residual leakage or difficulty with urination. Both of these are implanted devices, so there is a risk of infection. We do have a very specific protocol that we use in order to reduce the risk of infection, including antibiotics during and after the operation, and special wash we do beforehand. That does not make that risk 0, but does reduce it to the very low single digits. As incontinence is often a side effect of prostate cancer treatment, most insurance companies do cover placement of these devices. We will verify that you have insurance coverage, and based on the testing that we do in the office beforehand, these are usually covered, but we will beforehand verify that. So this is kind of step 1. I think logging into a webinar like this, if you've logged in to discuss incontinence, the next step, you can log into fixincontinence.com, have questions answered, or you can make an appointment. Many men with stress incontinence already have a urologist, because the most common reason is because of an intervention because of prostate cancer. So when you see your urologist that did your prostate cancer treatment, you can tell them that you went to a webinar like this and you'd like to talk to them about options for stress incontinence. And if it's someone in my practice, a lot of my partners send to me to discuss these in more detail. I kind of jumped ahead on these ones. So any urologist can really begin the treatment on stress incontinence, but you really want someone that's a prosthetic urologist, someone that does a fair number of these artificial sphincters and slings, to really discuss the pros and cons of each device and understanding which is the best option for you. In summary, for stress incontinence, it's common, especially in men with prostate cancer treatment. There's a variety of treatments. In the short term, really working with ways to cope and working that you incorporate your pelvic floor muscles appropriately. And then long term, especially if you've tried those coping mechanisms and muscle strengthening, a sling or an artificial sphincter are really great options for someone for a permanent solution for their leakage. So that was kind of the two parts of this talk. that's the stress incontinence. I'm going to focus next on erectile dysfunction, but Mike, can you tell me if there's any questions on this part, and then before I move on?
So the questions so far are not related to incontinence.
Okay, so should I move on to the second half and then questions at the end? Perfect.
Perfect. Yep.
Let me get my drink. Okay, so understanding erectile dysfunction and what the treatment options are for ED. So what is erectile dysfunction? Who has it, and what are the causes? So erectile dysfunction is the persistent inability of a man to maintain an erection firm enough to have sexual intercourse. It's really common, and I think it's even urologists are surprised when they see these numbers about how common this really is. 1 in 5 Americans over the age of 20 and more than half of men over the age of 40 have some degree of erectile dysfunction. This really ends up being about 40 million American men and very, very common. How an erection works. So not pictured on this slide here is the brain. You know, I think that's step one. You have to be in the right scenario with low stress, having the right amount of testosterone. Testosterone is the hormone produced by the testicles in order to give a man sexual desire and the libido. Once that signal then leaves your brain, it sends nerve endings to the penis, and then the penis then fills with blood. You have to have normal blood vessels in the penis that are able to expand and allow the erection to occur. The penis itself, in the simplest of terms, is really made of 3 tubes. If you look here, side by side are these 2 pink erectile bodies. These are what fill with blood when a man gets an erection. There's a central artery that is then surrounded by veins. And when a man gets an erection, the artery dilates, sending more blood into the penis, allowing those erectile bodies to then fill with blood and get erect. It's surrounded by a sheath or a corporal body. That is what keeps the blood inside the penis until the erection resolves. Underneath is the urethra. That's the tube that you urinate through. Having erectile dysfunction can have a large impact on a man's quality of life. If that's what brought you to this talk, you know that what brought you here, but lots of issues, and definitely can really affect a man on their day-to-day basis about having erectile dysfunction. So ED really does correlate to many other health issues. As I mentioned, in order to get a good erection, you have to have blood flow into your penis. And so therefore, the most common reason that we talk about having erectile dysfunction is a vascular problem or a blood flow problem. If blood doesn't flow well through the rest of your body, it's not going to flow nicely into the penis. Additionally, diabetes can affect both nerve endings and blood vessels. And those are, as I mentioned, how to get an erection, you have to have normal nerve endings that can send the signal to your penis, plus blood vessels are able to dilate and fill the penis with blood. Different medications, especially blood pressure medicines, can affect erectile dysfunction, as well as pelvic trauma, and also prostate surgery can affect your ability to get a good erection. So I'm going to focus a little bit on each one of these topics on the most common causes of ED. Some will pertain to some people and some not to others, but I think it's nice to see that how common it really is and how other health issues can have an effect on erectile function. So starting off, as I'm talking about diabetes. Diabetes is really common. About 15 million men in the United States have diabetes. Erectile dysfunction occurs much more early in men with diabetes, about 10 to 15 years before the general population, a diabetic man may experience erectile dysfunction. And because diabetes affects blood vessels and nerves, oftentimes erectile dysfunction is less responsive to pills for erectile dysfunction as opposed than in men without diabetes. As I mentioned, the diabetes can affect the blood vessels, and therefore causing blood vessels in the penis and throughout your body not to be as expandable, causing endothelial damage. It can also cause neuropathy. Neuropathy is damage to nerve endings. very commonly people talk about diabetics having difficulty with their fingertips and their toes, having loss of sensation to some degree. The same can happen to the tip of the penis, where men don't have the sensation, and sometimes the skin feels the same, but the nerve endings, the response to the penis is not the same because of damage to the nerves from the diabetes. Ways to control diabetes. If you have better control of your diabetes, you have a lower chance of having erectile dysfunction because of your diabetes. But as men age, if they have worse control of their diabetes, if they take diuretic medication, or they also have heart disease, those can also affect their erectile function. Excuse me. All right, erectile dysfunction and heart disease. So as I mentioned, inside the penis, there are the penile artery. This artery is really small. On each side, it's about 1 to 2 millimeters in size. If you compare that to the coronary artery, which is about 3 to 4 millimeters in size, or the carotid artery, which is about 5 to 7 millimeters in size, it is significantly smaller. And I mention that because anyone that comes to me and says, I have a history of heart disease, I had stents placed, or I had a stroke and I had narrowing in my carotid arteries, that is a significant risk factor of having erectile dysfunction. And vice versa, men that have erectile dysfunction do have a higher risk of having these other things like heart disease and stroke. If you think about narrowing occurring in those small blood vessels inside the heart, it's very, very common for that man also to have narrowing of the blood vessel inside the penis. So in any man with heart disease, exercise, diet, increasing physical activity, quitting smoking, reducing their stress may improve their erections, and may, as it reduces their heart disease and helps with their blood pressure control. Testosterone. So I mentioned this at the beginning. The testicles have two functions. One is to make testosterone, the other is to make sperm. Testosterone is made by the testicles and gets into the bloodstream. Testosterone helps with desire, libido, drive, helps the man have better concentration, also helps them stay fit and stay lean. As men age, oftentimes their testosterone drops. Approximately 4 out of 10 men over the age of 45 do have a low testosterone. Low testosterone does also correlate and kind of is common in men that have some of the other things I already mentioned. Men that are overweight, men that have diabetes, men that have heart disease or high blood pressure also often can have a low testosterone. Those men often present to me with erectile dysfunction, but sometimes come in to their primary care doctor with other things like fatigue or feeling run down, just a decreased sex drive, having difficulty with concentration. The way you check a testosterone, it's a blood test. And so testosterone blood test should be performed in the morning. It's most accurate if a testosterone blood test is performed before 10 o'clock in the morning, as that's when the testosterone really is the highest. I recommend that anyone that's having their testosterone checked should do it twice before they start treatment. Most commonly, testosterone treatments are lifelong treatments. And so before you start on any type of therapy for testosterone for the long term, I think it's important to get at least 2 blood tests in order to confirm that it really is accurate that your testosterone is low. If a man has low testosterone, confirmed twice, it is reasonable to talk about starting them on testosterone replacement therapy. Testosterone replacement therapy can be given lots of ways. There are some off-label therapies that we can give that are pills that can stimulate your testicles to produce more on their own. I tend to do that for men with desire for future fertility. They want to have more children. But for men who no longer want to conceive, we can give gels, patches, or injections, or pellets, different ways of giving you the testosterone directly. So your testicles would no longer make the testosterone, and you can get testosterone absorbed through the gel or the patch or the pellet, or a new oral therapy that can give you testosterone. Prostate cancer. So This is a very similar slide to like I showed previously, showing that the bladder sits here, the prostate here, and then the urethra runs through the prostate. When the prostate is removed, the neurovascular bundle, which is the nerves that take the signaling for an erection down into the penis, is pulled off the prostate in what's called the nerve-sparing prostatectomy. You can see the nerves here remain. Just the sheer act of moving those nerves off the prostate in order to remove the prostate can cause some damage to those nerves. And sometimes those nerves are damaged with the surgery itself. Sometimes when they're just peeled away, there's recovery of erections after a prostatectomy. And sometimes those erections do not return fully. Overall, about 50%, so half of men that have their prostate removed, have worsening erections a year after their surgery than men than beforehand. In addition, men that have radiation therapy, about half of them also have worsening erections after their radiation therapy. And men that have both their prostate removal and radiation therapy really have two hits and have a much higher chance of having erectile dysfunction. All right, Peyronie's disease. So Peyronie's disease is often confused with erectile dysfunction. They really are two separate things, but they do go hand in hand as they affect really the same patient population. Peyronie's disease is a plaque that you can see here in the sheath that in the erectile body. So what happens is a man gets a small injury, which sometimes is more common in a man with erectile dysfunction because they have a higher chance of some bending of the penis with sexual activity. And what happens, they have abnormal scar formation, or this plaque then forms in that sheath. That plaque is less elastic than the rest of the penis. So then when a man gets an erection, this plaque does not stretch as much as the rest of the penis, and therefore causes curvature or instability of the erection at the area where that plaque is present. This can cause difficulty with penetration, anxiety about the appearance of the erection, or pain for the patient or for their partner. Peyronie's disease can be treated in multiple ways. I normally start patients on some stretching regimens or a use of a traction device to stretch the penis and allow for lengthening of that plaque. If the therapy does not help, Xiaflex, which is a collagenase or an injection into the plaque to break it down, has been helpful in order to elongate the plaque. That's performed in the office. It's normally on 8 separate occasions where a man comes in and has injections into the plaque, or surgical procedures. Surgery could be either a penile plication, where we say that plaque is stable and we put some sutures in opposite that plaque in order to shorten the opposite side of the penis in order to allow for straightening, incision or excision of the plaque with a graft placed, or placement of a penile implant, which is really best for a man that has erectile dysfunction and Peyronie's disease. Okay, so that was a very quick summary of really the leading causes and comorbid conditions that can cause erectile dysfunction. Now I'm going to delve into what are some of the treatment options for men that have ED. So first of all, if you have ED or erectile dysfunction, which I said is really the inability to get or maintain your erection that's sufficient for sexual activity, you should probably start by talking to your primary care physician, your family care doctor. More and more, probably in the last 20 years since Viagra has been more readily available, lots of primary care doctors feel really comfortable prescribing medications for erectile dysfunction and more comfortable, I think, discussing erectile dysfunction. So start with your primary care doctor is a very easy first step if you're comfortable with that. If not, almost any urologist should be able to talk to you about ED and start you on the path towards your treatment options. Someone like me, who's a prosthetic urologist, someone who really focuses in options for erectile dysfunction treatment, are always happy to see you, and I'm always happy to see anyone that wants to come talk about ED. I would say a lot of patients I've seen have already tried some of the other options, which I'll discuss, and really focus on the next level of treatment, beyond pills. So What are those treatment options? Those include pills, Viagra, Cialis, and many others that are on the market now for a while, are very helpful and are usually the first step. Other options include injections into the penis to help get an erection, suppositories, which is a small pellet that is pushed into the urethra to dissolve, a vacuum erection device, which is a cylinder placed over the penis to pull blood inside, and then maintaining the erection with a ring on the base of the penis, or a penile implant, which is a surgical procedure where we replace the inner parts of the penis with cylinders that are usually controlled by a pump that sits inside the scrotum. So I'm going to talk about each of these in a little bit more detail. Oral pills or PDE5 inhibitors are medications that allow the blood vessels in the penis to be more susceptible to dilation. So what happens is when a man is stimulated and they've taken a pill like this, they should get a better erection with this medication in their bloodstream than that same man would get without that medication in their bloodstream. Viagra especially, and some of the other pills really work better on an empty stomach. So normally we have you take the pills about an hour before sexual activity on an empty stomach. About 70% of guys have an improvement of their erections with these medications. They are safe medications with some potential side effects, including headaches, flushing, upset stomach. You cannot take these medications if you take nitrates, which are medications given to men with chest pain. And like I mentioned, about 70% of guys get a nice erection or improvement of their erectile function with pills. And so I do think it's a really nice place to start. The medications do not cause erections. They allow you to get a better erection when you are, when you're engaging in sexual activity. So the thought being, if you take a pill like this, if you have foreplay, if you start engaging in sexual activity, you will get a better erection than you would have if you had not taken that pill. So for men that have failed pills, one option is a vacuum erection device. A vacuum erection device is a cylinder that goes over the penis, and what it does is it mechanically pulls the blood into the penis. Once the blood is then pulled into the penis, you place this ring on the base of the penis. This ring then maintains the blood in the penis. Because that ring is very tight, there are some complaints about lack of sensation or discomfort from the ring. The ring can only really be left on for about 20 minutes or so, and then needs to be removed. Most men can get a good erection with a vacuum erection device, and I do have a fair number of men that are happy with this device because it's a one-time purchase. It's outside the body. There's nothing invasive about it. But I do have men complain about that ring and therefore don't love it so much. That ring can then cause blocking of the ejaculation, can also cause some discomfort or black and blue at the base of the penis. A urethral suppository, this is a medication called Muse or Alprostadil. This comes in a pre-packaged unit that needs to be refrigerated. The medication, this is an applicator that goes into the opening of the penis and then deposits this small pellet, if you can see right there on the screen, into the urethra. That pellet is then dissolved by the heat of your body and absorbed by the penis itself. This is a medication that then causes the man to get an erection spontaneously, usually within about 10 or 15 minutes of the time that the pellet begins absorbing. It's a little bit non-specific because it's being absorbed by the penis. It's also being absorbed by some of the surrounding blood vessels. So sometimes people do get a drop in their blood pressure. They get lightheaded or dizzy from it. I often recommend that men do this for the first time in the office so we can check their blood pressure and make sure they're not going to have that side effect at home. About 40 to 50% of guys have a good response rate to it, but many men don't continue to use these suppositories. I have had really good success in men doing injection therapy. Injection therapy is the same active ingredient, Alprostadil, that's then injected into the penis, into the corporal body directly. Additionally, I will often prescribe something called trimix or triple mix, which is Alprostadil with additional agents to give a better result. This is a tiny needle that's injected into that corporal body. And so, as I mentioned at the beginning about what makes up the penis, there's these two erectile bodies, the two top tubes. That's what fills with blood in order to get an erection. And this tube on the bottom is the urethra. The two upper tubes connect to each other, so you only have to inject yourself once into the side of the penis, delivering the medication. The medication then, within 5 to 10 minutes, stimulates those blood vessels to dilate and gives a good erection. Sorry, there's someone at my door. The response rate is high. About 60 to 70% of guys get a good response to these injections. And I have many patients that are very happy with these injections. There are some risks. Number one, the medication is very potent. So there is a possibility an injection like this can cause what's called a priapism, or a long-term erection. An erection that lasts for more than 4 hours is an emergency. And so really, to reduce the risk of that happening, the first time you do these shots, I usually teach you how to do the shot in the office. Me or my physician assistant will then work with you, making sure you're comfortable doing the injection and making sure your response is appropriate, so that way you don't end up in an ER, that we really can, if you have an issue, we can treat you in the office. That said, most commonly men have a nice response in the office, feel comfortable doing these injections, and lots of men have a good response. And finally, I want to talk about a penile implant. A penile implant is a really great option for men that either have tried the other options and they haven't worked for them, or those other options really don't work for them or are not appropriate for their lifestyle. What's great about a penile implant is it's a device that's placed inside the body, replacing the inner parts of the penis, but then it's inside your body and it is always with you and is completely concealed. It's a very effective procedure. Over 90% of men are happy that they had it done. The devices usually last around 10 to 15 years. There are risks. This is a surgical procedure where we replace the inner parts of a man's penis with these cylinders that are controlled by the pump. And there is risks, including infection, bleeding, injury to surrounding structures. Like I said, the average device lasts around 10 to 15 years. If the device has a problem, it does need to be taken out and revised. There are different types of options for implants. There is something called a spectra, or a malleable implant that only replaces the inner tubes of the penis in those two cylinders. So these are two cylinders that are just bendable, allowing a man to really have a firm penis at all times. They bend up for sexual function and then bend down when they're wanted to be more concealed. Something called an ambicort device, or a two-piece device that has cylinders and a pump. The pump also acts like a reservoir, so a man has about a 60 to 70% full erection at all times. Then you take about 2 or 3 pumps in order to get a full erection by squeezing this pump. And then the most common device we place is something called a 3-piece device. This has the 2 cylinders in the penis, a more complex pump that sits in the scrotum that allows filling by squeezing this pump here, shifting fluid from a reservoir into the cylinders. And when you no longer want to have an erection, you press the small button that you can see here, allowing the cylinders to deflate and the fluid to go back into the reservoir until next use. You'll see that the only one that's yellow is this one that is this AMS 700 or the 3-piece device. That's because this device is coated in antibiotics. This antibiotic impregnation reduces the risk of infection of these devices. So this is a quick animation of how this works. So if you see here, the cylinders are inside the penis itself. When you squeeze the pump, you're shifting the fluid from the reservoir into the corporal bodies, into these 2 cylinders. You then have an erection that you can keep for as long as you desire, and then you press a release button, and the fluid then shifts back into the reservoir. All right, and this is a patient demonstration of what an implant would look like. Inside you can see that brought up to the skin here. Here is the pump. You can see the man squeezing the pump there, and then the fluid is then filling those cylinders. The average man, takes about 25 to 30 pumps to really fill the device completely. You can see once it's inside the body and it's pumped up, you can see it's a nice erection, but everything is concealed inside the body. And then when you no longer want to have an erection, you pull that pump up to the skin, you find that release button, which you can see right there, and squeezes that button, and that opens a valve, allowing the fluid to then leave the penis. And then you can give the penis a little bit of a squeeze, and that gets the rest of the fluid out. So the device stays very concealed and really having no erection once it's completely deflated. Very highly satisfactory procedure. I think, again, like I mentioned with like the sling, that artificial sphincter, I think patient selection, really explaining what this device is and isn't and how it works is really important beforehand. Well over 90% of patients are happy they had the device placed and would recommend it to others. Additionally, patients' partners are often very satisfied with the device. I think I did mention these before. Placement of a penile implant does have risk. It is a surgery. Therefore, there is a possibility that there's a mechanical failure, that there's pain associated with the recovery process. There is a risk of an erosion or the device not sitting appropriately that needs to be revised. The risk of an infection sits somewhere about 1 to 2%. And the antibiotic coating and the regimen that we use in order to give antibiotics before, during, and after the operation really do reduce the risk of infection. Penile implant is designed to be a permanent solution. Allows for spontaneity because it's always inside you and always with you. It has a high patient and partner satisfaction. It's been out for over 40 years and over 500,000 have been implanted. Insurance often does cover placement of penile implant. This is one of the things that we would verify before you had the surgery, that you knew what your coverage was and if you had any deductibles associated with it. We work together with Boston Scientific and they do a really nice job of really helping us verify the insurance so that you don't have any surprise bills at the end. And then taking a step back to talk about erectile dysfunction more globally, it's a really common problem. And like I mentioned at the beginning, it's really half of men over the age of 40, which really is, the amount of men that have ED is just, astronomical. And there are lots of options for treatment. In some men, it's just trying the pills or really doing the, maximizing their control of their diabetes or their high blood pressure medications. And in some men that the pills and the medical therapies really haven't worked, there are lots of other options, which hopefully I mentioned many of them today, which are helpful, including the injections and the vacuum devices and the penile implant. Step one, I think, for many people is coming to a webinar like this and hearing what some of this information is, talking to your partner, talking to your primary care physician, or making an appointment to discuss some of these options. These are the disclosure slides. Mike, do you want me to introduce Cliff and then go from there?
I think that'd be great. Yeah.
Perfect. All right. So we're really lucky to have Cliff Pollock here. Cliff can talk about his experience with erectile dysfunction, and then I think in the end, Cliff and I will answer any questions.
Good evening. What you're going to hear basically is a story, that journey that I took with my wife from the time I had prostate cancer through today. Back in 2004, I was diagnosed with prostate cancer. And being the kind of person I am, even though there was only one spot that was positive, I decided to have the prostate removed. After I had my prostate removed, they put me on Viagra. And I will tell you, unfortunately, I went from Viagra to Cialis to Levitra, and none of the pills ever gave me an erection, even though I had taken them correctly without food. What they gave me were terrible, terrible headaches, to the point where I just couldn't put my head up off the pillow. So I went back to the doc at that point, and this was my regular doctor. And he said, oh, well, we can give you a vacuum erection device. So he gave me a prescription for one, and I bought it, and it worked. However, as you saw in the results of the slides, a lot of men give it up, and they give it up for a bunch of reasons. One of them is it is not spontaneous whatsoever. The second one is that little ring that they put on, which I call a tourniquet, when you take it off and slide it off the shaft of the penis, it's not bad, but coming over the head of the penis, it hurts. And it always seemed that the more excited I was prior to having intercourse, the longer it took to get it pumped up and to get the band placed. And after 3 months, I just gave it up and basically didn't know what to do at that point. My doctor didn't tell me go see somebody like a urologist or a prosthetic urologist. And I went into a major depression. And basically that lasted for 2 years. Luckily, in 2006, I got an invitation to a meeting kind of like this, but because of COVID, it was a live meeting. I learned about some of the other treatment options that were available. And looking at all the treatment options, my wife and I decided that the best treatment option for us was to have the implant done. So in 2006, I had my penile implant done. I will tell you, it was the second best thing I ever did in my whole life. Problems, there are no problems basically with it. Once you get through your recovery period, which usually lasts about 4 weeks to 6 weeks, you are ready to go anytime you want. You have an erection that you don't have to worry about. You don't have to worry about things like if you have the injections or the muse, they have to be refrigerated, things like that. This implant goes with you wherever you go, and it's just there all the time. What's really nice about it is, as my wife has said, if she didn't really know I had an erection and I was dating her, she wouldn't be able to really tell there was something inside me that wasn't natural. After 6 weeks, after 2 weeks, I went back to work. After 6 weeks, my wife and I were able to start to have intercourse again. My unit lasted me 14 years. And 2 years ago, I had it replaced. I'm going to be 76 this May. Hopefully it'll last another 14 years. And God willing, I'll get it replaced again. It's as simple as that. After 2 weeks, I did go back to working out with the guys at the gym, and they could not tell I had anything inside me. You did see on the, excuse me, on the video, it didn't look like the gentleman was very, very flaccid. I can tell you he wasn't. You can get very flaccid. You can get as flaccid as if you were coming out of a cold shower on a cold day in Alaska. I mean, it really gives you the ability to be as flaccid as you like, or to wear a, if you want to go around in a Speedo, you can leave it any way you want. It's as simple as that. I will say that I think one important thing is when you decide that one of these treatment options is right for you, that you include your partner in the doctor's office visits. I think it's very important because a lot of partners think that, oh, well, he's not responding to me. He doesn't love me anymore. He must be having an affair and all of this, but they don't understand what's going on. And the reality is, once they go and they understand what's going on, it's much easier. And ED is not just a male issue, it's a couples issue. And at that, I'll leave it and say, turn it over back to Dr. Goldenberg. And if you have any questions, I'll be more than happy to help answer them.
All right. So I was reading through some of these questions. Can I run through